John, lovely to see you. Thanks so much for being with us this morning.
Not at all. Delighted to be here, Ian.
Thanks so much. You've been busy, yeah? You've been busy during this pandemic, and what we said was, what have you been up to? What's been changing since this hit? And I think you and your colleagues are a prime example of that, because you haven't sat back. You've jumped on this whole pandemic and you've put something in place. So why don't you tell us what you've been up to?
Yeah, sure. Well, I suppose the key point is really our background. We're specialists in addiction and mental health issues, and when you're dealing with many of these issues in real terms, what you're dealing with is chaos. And our job in that sort of environment is putting some structure into chaos. So when the pandemic broke, really it's another form of chaos that has come along. And so really we started watching this because we got some strange links with China, which I won't go into, but we started looking at this sort of September, October, November last year, when things started to merge out of China. And then really from February, March this year, we started looking at introducing testing when it was clear what was, the pandemic was going to break. So we've been working with a number of clients, two types really: those who had to keep essential services working straight through the pandemic, but also helping clients prepare for the return after the lockdown. So we've got two very slightly different approaches, really, requiring similar but slightly different, responses and sort of techniques for addressing them. So we've been doing a lot of testing with right from the beginning, both for the antigen PCR testing, but also we supply the antibody testing, which is a marker for being able to return to work. We've been doing that really since March, and so we've had an interesting track record all the way through, when unfortunately in wider society it's been harder to get things like tests and things like that. So what we did was, rather than profiteer from the situation, we set up, as you said, the 2020 fund, and we've been able to dish out, I think we're up to around £10,000 worth of things like hand gels, sanitizers, face masks, but also tests. We actually supplied them to GPs and nurses on the front line from the beginning. And we've also, put money into food banks and basically any frontline services that needed it. From the beginning. So it's been a very busy time, and I would suggest in all cases, really the biggest thing we're dealing with is managing fear, which is an interesting one. It was great hearing Adrian talk, but that whole situation about we're in unprecedented times, and the normal sort of fight, flight, flop, freeze, befriend approaches to responses to fear don't work in this situation.
So, John, if you just go back to the 2020 fund there, that was interesting there, because we initially saw a clamour for things like hand gels and PPE, especially in care situations as well. A friend of mine, Paul, I mentioned earlier on, who ran healthcare, he had to jump on it quite quickly to get the PPE to keep his staff safe. And obviously we saw a little bit of profiteering as well from some of the pricing rising. Is that something that you identified?
Yeah, definitely. And to be honest, we took the active decision because it was a case of, certainly with some of the organisations we were dealing with, and we've worked with, and we've tried to support some great organisations like Age UK, Gateshead, North Tyneside, Learning Disability North East Network, for example. And those frontline services really suffered in those early days. So what we realised was there was a lot of profiteering, let's be really honest, with the inflated prices for PPE. And partly for all the right reasons. It's because industry business clients are also looking for the same products that frontline care workers would normally be using. So there was a huge demand and rush all at once. And so this is why, with the profits that we bought PPE at quite inflated prices from providers, purely just to grab it. Because actually, if you've got a small charity or a small organization who are on limited funds already, frankly, they just weren't able to cope, and the supply coming through from government just wasn't there.
Yeah. So John, just in terms of what Recovery for Life does, do you want to give us a bit of an overview? Because I know you're doing some fantastic work in the region, and I think this region unfortunately needs that work done, because you've got some quite sad statistics. I'd love you to talk us through that.
Yeah, sure. Well, and this is part of the reason why we set up Recovery for Life, really specifically working with business, because we identified a huge number of unmet needs. And if you look at the Northeast as a whole, unfortunately, we're at the top of the tree and top of the league tables in a number of areas which we really wouldn't want to be. So if you take, first of all, we've got the highest number of drug deaths in England each year. We've got the highest level of alcohol-related deaths. A few years ago, it was 22% higher than any other part of the country. We've got the highest level of opiate prescriptions and prescribing being dished out for sometimes good reasons, etc. But we've got a huge opiate issue. We've got the highest level of codeine-based products sold over the counter anywhere in the UK and possibly in Europe. And then, we've got some of the worst mental health statistics, which this pandemic are actually going to make a lot worse. And that's going to be the big challenge going forward for businesses, to be honest. And at the same time, all of this sort of comes together. We've got the highest suicide rate in the UK. And actually, in many of the cases, unfortunately, much of our work we're brought in to do is to, in the follow-up after a suicide or after an attempted suicide, or we're brought in by somebody to support a family member an employee whose family member might have taken their own lives. So we're seeing it, that plus the very, very high levels of cocaine use and drug use, particularly cocaine in the Northeast, don't really help all those underlying sort of other health issues that we've got some of the worst health inequalities anywhere in Europe, in some of the worlds, particularly Middlesbrough and Hartlepool, but Sunderland as well. And it's no surprising if you look at the death rates through the pandemic, actually many of those are, if you look at Sunderland in particular, it's really not surprising that this situation has sort of evolved. The challenge is how businesses look at taking this forward in the new world, because it certainly won't go back to where it was. I would agree with Adrian, there's an opportunity at this stage to redefine that and to actually work in a very different way. And one of those key issues that businesses will have to get sort of involved in is the wider health and mental health of its workforce going forward. So we're seeing a huge increase in trauma-related inquiries. So things like PTSD and things like that, OCD, general anxiety disorders, but we're seeing those going through the roof, and that will only continue, particularly if there's going to be a second wave, which is expected.
John, that was absolutely really hard to hear, if I'm honest. It was really tough to hear, and I didn't know a few of those stats, but it's not good enough. And there must be tough working in this role, because you see that, and I guess you can help it, okay? You can help the symptoms, but how do you treat the cause, John? What can you do from Recovery Life? Can you bang a drum? What do you do?
We do a number of things, and most people will never have heard of us before, because we don't actually, virtually all our work is by referral, and we don't really advertise ourselves. We do quite a lot when we're members of a number of industry bodies such as the Chamber, NOF, NEAA, etc., etc. But I think the key point here is in pointing these sort of things out. We don't want people to be disheartened with this, because the key thing here is our job is, and our approach is not to frighten people with these scary statistics. Our job is to highlight them, because we firmly believe if you know what you're dealing with, you can deal with anything. And actually, we've proven this with the clients we work with, and some are from very small operations up to very large international companies. What we find is actually there is a genuine will from the right companies. Now, we're very lucky. We've got a great client base who works with us, and we have proper dialogue around these issues. But it's usually we're brought in when something's gone wrong. So we do interventions, direct interventions, which is quite unusual for a private occupational health type service. Yeah, but we'll go in and sort the problem out. If somebody can't get on a waiting list to see a psychologist for 2 years or 3 years or something, we had one this week, then we'll see somebody in 24 hours. And we're used to dealing with complexity. So the interventions bit, the treatment bit, is quite often brought in to sort out a problem. And we end up quite often working backwards to looking, okay, well, how we manage this is by actually through training and awareness, particularly at supervisor level on the ground floor, because it's quite easy to get leadership buy-in. That's usually not the problem. It's usually the middle level of the people who are actually going to have to implement some of these conversations. And it's like Adrian said, it's about understanding those smaller teams on the ground. And then before that, we use even our approach on simple things like drug and alcohol testing, which is required in most sort of safety critical roles. We do it in a very different way. And actually, for a good example is if somebody was to fail a test, we don't let them out of our sight until we know somebody's going to be okay. And we actually put in a little bit of advice and support to direct people to problems if they have got a problem with drugs or alcohol. Quite often, the main bit of concern that's raised with this is, how am I going to tell my wife, is the biggest question that gets raised. And we talk through those issues, because what we're trying to do is nitpick. You can't catastrophize about these issues, but you've got to be aware of them. And the three together, those sort of components, are where we're finding we're making the most impact with businesses, to be honest.
It's really interesting, John. So what it sounds like there, then, that you may react to an issue, but then you suddenly go into proactive mode with the organisation and try to stop the spread, maybe, or try to address any particular issues that might be there.
Yeah, no, absolutely. And I think the key to doing this isn't about us sort of riding in on white horse and sorting everything out. It's about empowering companies, businesses, and leaders, but at all levels through the organization. So we work really well with union reps and with union and work council representatives. It's interesting, quite often we'll be brought in and we'll say a drug and alcohol testing program. We always recommend an amnesty period, and we work with people to come forward, because the reality is people use drugs. There isn't a night out you can go out on the northeast and not come across drugs. They're everywhere. But actually, it's about winning the hearts and minds argument of explaining why that's an impact on the business and how people still get hurt. 60% of workplace fatalities still involve alcohol after all these years. So if you look at that, even though we've got a fairly good record, it's sort of plateaued. Nothing's really changed from that. That has to be around behaviours. And that's the real challenge I think businesses are going to follow. Plus, what you're going to see now coming forward there will be redundancy programs and things like this. But what's really interesting, some of the programs that we've worked with, some of our clients, we've been working with them to build in where they think there's going to be a redundancy program. For example, we run specialist EAP lines, for example. So it's more really as an identification for more complex needs, shall we say.
EAP?
Sorry, say again.
EAP?
Yeah, sorry, employee assistance program, like helplines. But we do it, it's more of a specialist role, but we do them. And one of the things that we've noticed is some of the clients who were a very good client, was the first one to do it a few months ago, is looking at actually building into redundancy plans and policies, that support line for 6 months post redundancy. Now that actually is quite a fantastic way of thinking about it if you realize you've got to make difficult decisions.
Yeah.
And actually, as I said, we've got some fantastic businesses we're working with. And I think there is a genuine will for those who are thinking about this and aware of what the real situation is to get it right.
Yeah. How can you support leaders in this current situation, John? So leaders are going to be really keen to get their workforce back in. How can they be sure that it's the right thing to do, not pressurize staff? Because I think we've seen a few, well, I've certainly seen posts on LinkedIn about some staff from the HR point of view not willing to return right now. There might be concern there. So have you come across this?
Yeah, we see it all the time, and really interestingly, it sounds strange, but a lot of the testing that we do, and particularly with we have a whole risk management system, which looks at 4 different levels of risk, and the first is the risk to the business of people coming back. Now, a lot of that is about physical sort of distancing and things like that, and measures or within the workplace, managing the physical environment. But the second level of risk is actually the fear of employees returning. And the real fear is that they'll bring back something to the family or to themselves if they've got underlying health conditions, or to the family, friends, its neighbors, etc. And then your third level is actually around where you need to identify people who either previously had issues with sort of underlying health conditions or mental health conditions. There's a lot of work to be done around sort of trying to identify some of these subsets within the workforce, because they need slightly different approaches. But what we have found is where companies have offered, particularly the antibody testing, as part of their return to work programs, and very much as an offer of, could you, basically, would you like a test? Everybody has really snapped up on this. And one company, I saw the proof of this, was part of our role is when people have tested, if they've tested positive, and we break the news to them and direct them into the appropriate services through NHS or, local PHE, etc. What's interesting is the number of people who've said to us, they never would have thought that the company believed so much in them, or, thought so much of them, to test them and, in this case, their families. So when you've got a company doing something that they can't get elsewhere, for example, it totally redefines the psychological contract between employee and employer. And testing in this context has become a reassurance. Say, don't worry, come back. The physical environment's already sorted out. We've got the policies in support. If you're struggling or if you're worried about coming back to work and it's impacted on, we've all been isolated, we've all been stressed, etc. There is a support role here. Plus, we'll actually, if you want, you can have testing. And it's a very cheap way of doing it. Tests aren't expensive for antibodies. Then actually what you're looking at is redefining that relationship and recognizing the fears that people have. Where people don't recognize them is where it's brewing a storm for 3-6 months' time. And that's really what we're seeing. But I think that whole redefinition of the psychological contract is what we're really seeing now. And I would hope to see that's the greatest benefit that will come out of, basically post-lockdown.
Just in terms of the testing, John, I think we heard a lot in the press that some of the testing wasn't given the correct results, and some of them weren't fit for purpose. What's your thoughts on that?
I think there were. I mean, when it first started, I'll be really honest, although we use sort of the government guidelines, PHE guidelines, we use them as a floor, not a ceiling, if that makes sense. Our main focus, we looked abroad, we looked at South Korea, we looked at Taiwan, we looked at places like Greece, Germany, New Zealand, and we looked at what they were using. So the tests that we use, for example, there were a lot of dodgy tests on the market, and even the Chinese government clamped down on these. So anything that's exported, most of them are made there. Anything exported has to be certified by the Chinese government now. Okay, but the real point here is there were a lot of problems with accuracy. Some of them just didn't work, but there were a lot of good tests available. And I think the problem here is you either take the view of it's either a bad test, which is what the government said in the early days, is a bad test is worse than no test. Well, actually, fundamentally, I disagree with that, because at least it's an indicator. Yeah, and so it was really interesting. But the second thing is, if you take the test we use, they've got like 98% accuracy levels, 98.7, I think it is, or something like that, on sensitivity and specificity, which are the two contrasts. To put this in context for people, we actually put out a post comparing the accuracy levels to other tests people are used to. So the tests that are being rejected or were rejected in the early days, certainly the ones we were using, for example, they weren't actually rejected, but they actually were of the same accuracy levels as home-based HIV kits, hepatitis kits, diabetes kits, pregnancy tests. So actually, when you look at the parity between them, there's a fundamental flaw in the logic. If a home HIV test has an accuracy level of 95% and is acceptable, but you're rejecting a 98% antibody test, that doesn't make any sense. And it's not, more importantly, what other national governments have done in their programs. So that's not a really, don't want to get into the politics of it, but there is a fundamental flaw in what the messages have been about testing going out.
So, John, it sounds like you and your colleagues really jumped on this. What made you? I know obviously you've got the background in the drug and alcohol and that kind of stuff. Where did the decision come to dive straight into this? Was it forced by employers? Did they ask you to do this, or was it a decision that you made?
It was a combination, because there was a combination of things that we've seen, because as I said, we've got a great client base, and we have previously had to turn around where we didn't think the companies had the same sort of ethos or values that matched with us. We have had to write to people and say, we're not the right provider for you. So I think the very first thing is we've got a great relationship with with the clients that we've been using these. But what really struck us from the outset was the same clients were turning around to us, a number of them saying, we don't know what to do. It was as simple as that. What are the options? And it was actually some of those conversations which triggered, we said, okay, well, look, we know this weird thing's happening in China because we had these additional links, because we're involved in martial arts. So it's actually through those sort of routes that we actually had links. And we thought, okay, well, what are other people doing? And that was the trigger for it. And the thing is, a test in itself is only one component. What you really need to look at is understand, and this is why we developed the risk framework, which is a whole system, which is really to look at understanding who your employees are. And it's not just about that risk. It's about, okay, lockdown will do a certain role of it. Will help in a certain way. How do we get people back and safely, and understand that A, they're not going to transmit to others, B, or as far as we can control it. Secondly, they're not going to kill their own families by going to work. That's really what the fear is, and the bit by coming back and transmitting back. And then you've got actually about, okay, well, you've got a real issue around health and safety. Once people are back in the workplace, if people are coming out of isolation, it certainly isn't a case coming back to work. What you've got to look at is almost treat everybody as if they've been on 3 to 6 months sick leave and are returning to work. So the very first thing we're saying is almost treat everybody as a sort of phased return. And the very first thing you've got to do is go through all your health and safety procedures with people again, because they will have forgotten them. They'll be out of the loop on these. You've got to look at the impact on alcohol. Alcohol increase has jumped up anywhere between 30 and 50%, depending on what report you read. So actually what condition people are coming back into, and psychological sort of approaches that how they feel is going to be vital to this going forward. It's going to be a very interesting stage. And I think things like your drug and alcohol policies, we've recommended to our clients, for example, that they recirculate them before people return to work. Because actually just get people focused that, look, guys, we really need this to be a safe environment. This is for your benefit. And people have been locked away. And what we don't want is what's happened in India with the number, there's been multiple deaths on health and safety related deaths from people returning from lockdown on things like gas pipelines. One incident killed 12 people, injured 300. Because they were out of practice of following those standards, health and safety procedures. So there's a lot of work to do. It can be done.
I think that's a fantastic bit of knowledge to leave leaders with, John, the phased return, going over health and safety procedures again, and maybe having a document or a plan or a policy about how we get people back into the workplace that's actually sat and thought through.
Yeah, absolutely. And what I would say to anybody who's listening, if we're a great believer in collaboration and sharing information and advice. Nobody owns this stuff. So if ever anybody wants to just bounce stuff off us, or even if they're working with other people, it really doesn't matter. We're really happy to share what our learnings are, and we're very happy to hear if people have got really good case studies of how they've addressed it. And likewise, we're there to support people if they need it.
Fantastic. Thanks for that, John. Where can we find you then?
So you can come to our website, which is www.recovery4life.co.uk, or people will happily circulate my email address is just john.devitt@recovery4life.co.uk.
Great stuff. If anyone caught that, could pop in the comments, that would be great. John, thanks so much. Thanks so much. That was a really interesting insight. I hadn't thought about a lot of the things you've said there, so I really appreciate your time. And yeah, good stuff. Thanks so much, John.
And thanks for having me on, Ian. Thanks, Sam. Bye-bye.
Bye-bye.